Mr. S, 71-year-old female retired yoga instructor, Thrissur, altered sensorium, complaints of altered sensorium and involuntary movement of the body. 4 a.m. patient woke up from sleep, unable to do her daily routine, sitting in chair, staring blankly, irrelevant talk. 11 a.m. brought to emergency department, brain imaging done, sent to neurology OPD. 12 p.m. patient complains of ictal cry, uprolling of eyes and right-sided gaze deviation, clutched her hair with right hand, tonic-clonic movements of bilateral upper limb and lower limb for 3 minutes, with loss of consciousness for 2 minutes, and patient remained confused for 3 hours.
So
it's a case of altered sensorium with GTCS.
Altered sensorium. So part 1, before she developed the altered sensorium, what was happening?
Patient was having a aura, sir, 4 a.m.
So what are the common warning symptoms and signs of seizure?
Sir, there are different presentations are made. There can be motor features or sensory auras.
Okay. So they can be having simple memory lapse. They may
Yes, sir.
Psychic symptoms.
Yes,
maybe
sir.
some jerks here and there.
Yes,
maybe loss of consciousness. Carrying spells.
Carrying spells.
Okay.
Yes,
temporary confusion, fugue state.
Yes, sir.
So possibly the patient was passing through that particular event.
Yes, sir. Followed by patient went for a seizure.
So there was a gap between 4 a.m. to 12 p.m.
Yes,
after 8 hours only she developed
the seizure, sir.
Seizure, sir. Okay. Then she was confused for 3 hours.
3 hours, sir.
So age of the patient is 71.
Yes, sir.
So what do you think?
Sir, it's
is it
can be
epilepsy or
patient considering her age? We have to look for the metabolic causes also, sir.
Okay, that's very good. What are the metabolic causes you look for?
Sir, mainly hyponatremia, sir. Hyponatremia, also blood glucose levels. You have to, hyperglycemia can present also. Hypoglycemia can also present, sir.
Which type of hyperglycemia present as seizure?
This Hong can present, sir.
Hong
can present, sir.
What about alcohol?
Alcohol can also.
Yes. What about drug withdrawal?
Drug withdrawal seizure, but
yes.
Here we need to know the history.
What are the other common problems of elderly citizens coming with the seizure? Etiology wise?
Metabolic can be there.
Can cerebrovascular accident present like this?
Yes, CV can present, sir. Mostly embolic strokes can present as seizures, sir. Embolic and hemorrhagic stroke can.
Yes, infections?
Infections, sir.
Meningitis. Tumors?
Yes, sir.
Tumors?
Yes, sir. Tumors can also present with seizures, sir.
Okay. So, what's the possibility you expect in this patient?
Mostly considering her age.
Scanning was normal.
Considering her age, going for metabolic seizures, mostly hyperglycemic seizures, sir.
All those investigations became normal.
Okay, sir.
Okay, let's go forward.
Okay, sir. Patient has a past history of lumbar spondylosis for 20 years. Recent exacerbation of pain and paresthesia for which repeat imaging showed progression along with cord compression. Epidural steroid injection 1 month prior for the same.
And the patient is here. This is a green one. Can you see?
Yes, sir.
This is the patient, okay?
Okay, sir.
Okay, then.
With the glioblastoma.
Trace the patient's father.
Okay, sir.
Father is he died at the age of 42.
42, sir. 40 with the glioblastoma.
Multiforme.
Okay,
and
sir.
This particular patient has got 3 other siblings.
With who has died.
First one was
She has stomach at 62 years.
Second one was same glioblastoma.
Glioblastoma with
And the
56
patient
years.
is the third one. And fourth one,
CA lung,
but
65
that
years with
patient was found to have
TP53 mutation.
what we make out now. This family of cancer patients, no?
Yes, sir. Yes, sir.
What do you think?
Sir, possibility of glioblastoma
Okay.
or maybe CA lung with mets, sir. Sometimes it can with some metastasis.
TP53 mutation is a cancer predisposition state, no?
Okay, sir. Personal history, nil contributory, sir. Treatment history. History of epidural steroid injection on 9/3/2022 for persistent back pain. Nervous system, higher mental function, cranial nerve normal. Motor, bilateral knee jerk and ankle jerk absent. Coordination normal. Sensory, vibration impaired bilaterally. No neck stiffness. Provisional diagnosis, late onset seizure. Lumbar spondylitis with cord compression. MRI stroke screening done. No evidence of acute infarct or intracranial hemorrhage. Mild age-related brain atrophy and small vessel ischemic changes. EG, normal EEG in wakefulness and sleep. No epileptiform or localization abnormality. USG abdomen shows small grade 1 or 2 1 to 2 fatty change of liver. Small calcified fibroid in uterus.
So what do you want to do now? Family history of TP53 mutation.
Okay, sir.
How do you proceed further?
It's a X-ray, sir.
Normal. So
On goal CEA was 5.03, sir. Carcin embryonic antigen was raised, sir.
So what are the possibilities coming to your mind now?
Sir, colonic cancer can be possible.
Can be, okay. What is the final diagnosis we have?
Late onset seizure, lumbar spondylitis.
Okay. And later on the seizure under investigation. And okay. So what is a TP53 gene mutation?
Sir, and that's a tumor suppressor gene, sir.
Located
So,
on?
17p13, sir.
Okay. And what does it do?
It has the usual function is regulatory control, sir. Cell cycle, DNA repair, and apoptosis, sir. So once it is being mutated, so there will be uncontrolled proliferation may be there, sir.
So you have a lot of protection.
Yes, sir.
Okay. So what do you call this entity?
Leaf-Romani syndrome, okay, sir.
Yes. So what are the components of the classical one? The syndrome, okay.
Autosomal dominant, okay, sir.
Components are?
Sarcoma, breast leukemia, and
Adrenal gland.
adrenal gland, sir.
Call this SBLA syndrome. There are minor features also.
Melanoma, gastric carcinoma, lymphoma, Wilms tumor, lung adenocarcinoma, and colorectal tumors.
And there are criteria for classical.
Leaf-Romani syndromes.
Okay.
With classical Leaf-Romani syndrome, it's proband with sarcoma diagnosed less than 45 years. First degree relative with any cancer less than 45 years. First or second degree relative with any cancer less than 45 years or a sarcoma at any age.
This patient's father was 42 years.
Yes, sir. It's less than 45, sir.
Less than 45. So we concluded that possibly it's a case of
Leaf-Romani syndrome.
And she required the investigations and she said she'll come and has gone.
Okay, sir.
She was almost sure that she has one of these. Many years she got 3 of her siblings already lost. And they have investigated the children of those people. And a few of them are also positive for TP53.
Okay, sir.
So is there a treatment available for this?
Not sure, sir.
Gene therapy is available in some places, but not
Okay,
in
sir.
India. We
Okay,
don't
sir.
have.
Okay,
We
sir.
don't have gene therapy available. Okay. So you can engineer the genes and then try to change. Now the question,
Okay, sir.
familial versus hereditary are the same.
Sir?
Familial and hereditary are the same.
No, sir, different.
What is the difference between them? See, familial occur in cluster in a home, in a family. Hereditary
Yes, sir.
also comes in clusters.
Okay, sir.
Familial, you don't get any mutation.
Yes, sir.
Mutation is present only in hereditary form.
Yes, sir. Yes, sir.
And familial occur in the later ages, but hereditary may come at
Can present at younger ages.
Something like, what do you call that situation where newer generations are coming at a younger age?
Anticipation.
That's right. That's right. So, and the familial pattern, the disease doesn't follow the same pattern, but hereditary, if there is genetic mutation, same more or the same pattern is followed.
Okay.
So, Lee-Ferdinand syndrome is only a cancer disposition syndrome.
Okay, sir.
Okay, and
Okay, sir.
you have to identify them and then suggest that there are results available to confirm it, and then
Okay, sir.
goes for the genetic engineering if they are agreeable.
Okay, sir.
That's all what we can do.
Okay, sir.
Okay, so whom all you test for this?
Those who are at higher risk, sir, for that filling the diagnostic criteria, female with early onset breast carcinoma, BRCA 1 and 2 negative, and adenocortical carcinoma, choroid plexus carcinoma, childhood sarcoma, and prenatal testing and TP, family history of TP53 variant, sir.
Okay, so this is a very rare situation where we come across. And how do you follow up these patients with a positive mutation? How do you follow up? You can do clinical examination, no? Breast, etc.
Yes, sir.
Examination.
Yes, sir. Yes, sir.
You can do even X-ray test, but whole body MRI can be done.
Annually, sir.
Breast MRI can be done. Okay. Ultrasound abdomen may be done.
Okay, sir.
Urine steroids may be done, but there are specifications for each group.
Okay.
Condition we do. Colonoscopy may be another mode of investigation. So depending upon the scenario, you may do all these investigations, follow. Anyway, the people who are positive will be at a high risk for subsequent neoplasia, and they'll be in a very difficult situation. So what can be done for them?